Good morning, everyone. In conjunction of World Lung Cancer Day, I will be speaking to Prof. Dr. Anand Sachithanandan, a cardiothoracic surgeon and the founding president of the Lung Cancer Network Malaysia, LCNM. His work covers patient care, research, advocacy to improve outcomes for people with lung cancer. He continues to raise awareness and push for better access to treatment and support through his LCNM network. Good morning, Doctor, and thank you for coming on to our webinar today.
Good morning, Vishala. Thank you for the kind invitation.
So, Doctor, without further ado, I think my very first question is going to be a question many people have in mind too. What are some of the earliest signs or symptoms of lung cancer that people often miss? Is it a persistent cough or what is it?
So that's a great question to kick off today's session. Perhaps I can start by saying that, in the early stages of this disease, lung cancer, quite often there are no signs or symptoms. And that is why it is quite challenging, right? It's quite tricky, quite difficult to diagnose lung cancer early. And which is why we recommend and push the agenda for screening, which I think we'll talk about a bit later on in terms of who should go for screening and how do we screen for lung cancer. But to answer your question in terms of symptoms, as you rightly say, one of the most, probably the most common symptom, if someone were to have symptoms, would usually be a cough. Now, this is easily missed or easily dismissed. I mean, let's be honest, most of us will have a cough a couple of times a year. So it's a very non-specific symptom. And it can be attributed, as you know, to so many different, most of the time it's nothing serious. Having said that, generally, we recommend if one were to have a cough for more than 2 to 3 weeks duration, a persistent cough, or perhaps the nature of the cough has changed. We know a lot of people who are chronic smokers have a chronic cough, and the nature of that cough has changed. Then those are what we term as potential red flag symptoms, that should warrant further investigation. As a minimum, that person should, consult their primary care doctor and perhaps even push for a simple chest X-ray. Quite often, Vishala, the symptoms that the patient or a person may present with, and later on the signs, it is very much related to the size and the location of the tumor. So, if I can just elaborate a little bit, if we have a more central tumor, a lung tumor that is more in the middle of the chest, involving one of the airways or closer to the airway, that's when the person may present more commonly with perhaps a cough or a wheeze, and even sometimes more serious symptom like coughing up blood, what we term as hemoptysis. However, if the tumor or the nodule is more at the periphery, which means towards the outside of the lung, sometimes it may affect the lining of the lung or the lining of the chest wall, and one may present with symptoms like a bit of chest pain. We term this pleuritic chest pain, where it is often made worse. It's quite characteristic, made worse by perhaps a deep breath or inspiration or coughing. The other, I think, important sort of symptom or presentation we should all be aware of is sometimes, having recurrent chest infections, grumbling chest infections, flu-like symptoms that's just not settling. Now, that could also, most of the time, it's nothing serious, but it could also be a symptom of a possible underlying lung problem, including a lung cancer. So these are the things that we need to be mindful of and have a low threshold to get a medical review, a medical opinion. Yeah.
So it really depends where the tumor is in the lungs. Depending where that is, the symptoms that comes up can be different. So that's why you said, it can be non-specific when it comes to symptoms of lung cancer. But, doctor, I just want to speak more further on that. How can someone tell the difference between a persistent cough from a flu versus something that is more serious than lung cancer? Let's be honest, a lot of people who think they are persistently coughing, they can say, oh, they have allergies, they have flu, they have allergic rhinitis or sinus that probably is triggering all that. So what will you say the difference would be?
Yeah, so that's an extremely difficult situation, as you rightly mentioned, Vishala. The nature, some people have a chronic cough, it may be postnasal drip, it may be due to allergic reactions, chronic cough due to chronic tobacco smoking. So for those individuals, they should be aware if there's a change in the character, the nature of the cough. perhaps accompanying symptoms like hoarseness, change in the character of their voice. And, as I said, a cough is a very sort of common, non-specific, insidious symptom. Most of us have a cough a couple of times a year and it's settled, it's nothing serious. But if you have a persistent cough, so we do put a lot of emphasis on the duration. A cough that is persistent, not resolving after 2 to maximum 3 weeks, my genuine advice is please get it checked out. And perhaps the easiest way is to see your primary care doctor or a lung specialist and, ask for a simple chest x-ray. It's a very affordable test, very low radiation, and it could make all the difference.
Hmm. Yeah, so doctor, you spoke about persistent cough and blood coming out. So what is the does lung cancer cause pain early on? This is something that people always wait for. They wait for the pain to come, and that's when they will start taking action. And sometimes, they say when the pain is already there, it could be too late. What is your opinion on this?
Yeah, so I mean, thankfully, the whole idea is our whole aim is to try and pick up the disease early. Lung cancer is a very common cancer globally, including here in Malaysia. And the tragedy is it's actually a disease that can be cured. If we can pick it up early, we can offer curative intent treatment, which again, I think we'll talk about a bit later on. And, people can return to a normal quality of life and often to a very good longevity as well. So the challenge is to pick up the disease early. And we're going to talk about screening and how we do that. So in terms of, the question was about relating to pain. In the early stages of the disease, we very rarely see someone presenting with pain. As I said, the majority of patients, it's an incidental finding. It's a chance finding. In other words, they've had an X-ray or a CT scan, either as part of a health checkup or as part of an investigation for some other medical problem, and then it's a chance finding. We term this as an incidental finding. However, in those who present with symptoms, it is usually cough, recurrent chest infections, occasionally more seriously coughing up blood. Now, by the time someone presents with symptoms like difficulty breathing or loss of weight, or loss of appetite, or having pain, as I said earlier, a lot of this is we can correlate to the size and location of the tumor or the stage of the disease, the extent of spread. And that's usually quite an ominous sign, quite not a good sign. In perhaps more advanced stages of lung cancer, where it is spread outside the lung, spread beyond the lymph nodes, the pain can come, for example, if there's one of the places or one of the areas in the body lung cancer can metastasize to, can spread to is the bone. And then, but, obviously at this point, we're talking about more locally advanced or metastatic disease. Yeah.
Yep. Okay. So, doctor, I guess this is a question many people have. Besides smoking, what are the other risk factors for lung cancer that Malaysians should be aware of?
Another great question. So I think it's important I want to use this platform to share with the audience that at the end of the day, tobacco smoking still remains the single most common risk factor for lung cancer, the most identifiable risk factor for lung cancer, and the most preventable risk factor for lung cancer. And I would say still a majority of Malaysians who are diagnosed with lung cancer have a tobacco smoking history. In other words, they are either a current or former smoker. Now, having said that, Vishla, we have observed in the last 5 to 10 years this phenomenon, a rise in the incidence of lung cancer in the non-smoker or never smoker. And unfortunately, a majority of them are women. And this is a phenomenon we've observed not just in Malaysia or Southeast Asia, but globally, but I think more so in East Asia. And of course, there are various theories as to what or how this is happening. What I would say is that lung cancer that develops in the non-smoker or never smoker, in many cases, there is a genetic predisposition. We call
Yes.
this oncogene-driven lung cancer. Now, most diseases, including lung cancer, as you know, the etiology, the causation is multifactorial. In other words, for example, we all know of someone who may have smoked for 40 years, 2 packs a day, and he or she doesn't develop lung cancer. And then conversely, we encounter a patient or a person who's never smoked, who's led a very healthy lifestyle, and then they are diagnosed in their 40s or 50s with a lung cancer. So it is really the interaction of various risk factors and, genetic predisposition is a big factor. So what I would say for the non-smoker or the never smoker who develops lung cancer, we now know from a lot of data globally that a genetic predisposition, family history is a very, very significant risk factor. So if someone has and I would define that as a first degree relative, so a sibling, a brother or sister, perhaps parents, if someone has, parents or siblings who've been diagnosed with lung cancer, then unfortunately they themselves have an elevated risk. And that is one of the groups that we would advocate and push for screening. I do, however, also believe that, there are many cases of lung cancer in the non-smoker or the never smoker that is unfortunately we can attribute, although it's difficult to prove this, but I think it's due to, secondhand smoke exposure, ambient air pollution, microplastics, and secondhand, third-hand smoke. So we are seeing a rising incidence of that in densely populated, highly polluted kind of cities as well. So these are things, the government and individuals, we need community, society at large. We have to find ways to mitigate exposure, especially for children, especially for women, non-smokers, having the appropriate legislation, which we do in Malaysia, but enforcement, the enforcement,
Correct.
Smoking in eateries, smoking in public places, that inhalation of secondhand smoke, and it's a cumulative exposure over many, many
Correct.
years. That, one of the theories is that air pollution or even the secondhand smoke triggers an inflammatory response, and it almost awakens some of those dormant cancer causing genes. So
Oh, wow. Okay. That's
the theory.
interesting.
So that's some of the theories. So these are things that we can do. We can choose not to smoke,
Yeah.
and we can choose to some extent to control our environment in terms of trying to avoid, the smoky environment and exposure to secondhand smoke or air pollution. Perhaps a bit more difficult for us as individuals, but we have to lobby the government and other agencies to ensure that that pollution risk is minimized. Yeah.
Yeah. So it's enforcement policy, all that should be in place so that environment can be controlled. And, people who are non-smokers especially should be in a safe space.
Absolutely.
So, doctor, speaking about smoking, I'm very sure a lot of them are there out there thinking, oh, maybe smoking is not good. But what about vaping? We have this generation now that thinks vaping is safer. What are your thoughts on that?
So I think the short answer, Vishala, is we don't know. The jury is still out on this one, but there is growing evidence that, vaping is not good. It has been, put as I think the tobacco industry, or
Yes.
the wider tobacco industry, is quite disingenuous. They are now targeting a new generation, younger people. A lot of the vapes and the heated tobacco products don't even look, they look with fancy colors and fancy flavors. And they're going to enslave a whole new generation. And there is some evidence and data out there that vaping is a gateway to tobacco smoking, that youngsters, teenagers, young people who vape are many, many more times likely to go on to then take up, smoking. Why I say we don't know in terms of the lung cancer risk is vaping hasn't been around long enough.
Yeah.
Even with conventional tobacco smoking, as there is a latency period that maybe 15, 20, 25 years of intense heavy smoking before someone develops lung cancer, if it's
Correct.
smoking related. And we suspect that vaping would probably go the same way. I mean, vaping also is hazardous on the lung for all the non-lung cancer. It exacerbates asthma, COPD, and
Yes.
inflammation in the lungs. So it's something we definitely don't know enough about, but it's something that we have every reason to believe that it's going to be hazardous and could probably increase the risk of potentially increase the risk of a future lung cancer.
Lung cancer. Okay. So we have spoken about symptoms, we have spoken about non-smoking, smoking people, and the dangers of tobacco smoking. I'm going to move a bit into the screening. Is there a way to screen for lung cancer before the symptoms appear?
Yeah, absolutely. So this has been an area of interest and passion for me for many years. As you know, Vishala, and just for the wider audience, when we talk about screening for any disease, and certainly for cancer or lung cancer, means we want to pick up the disease at a preclinical or pre-symptomatic phase. So the person is not even a patient. We want to pick up the disease before you develop symptoms, at the earliest possible stage, because we know lung cancer, certainly, and I think most cancers, that the treatment that is offered, the prognosis, the outcome is very much stage dependent. So with lung cancer, the gold standard as it stands is still with the low dose CT scan, LDCT.
Okay.
There are different types of CT scans. A low dose CT scan has a low radiation dose. You don't need to fast before the scan. You don't need a prior blood test to check your kidney function. There's no contrast. It's a non-contrasted scan, and it takes 15, 20 seconds to be performed. It gives very detailed anatomical resolution of the lung tissue, and it's presently the gold standard to screen for lung cancer. Now, LDCT is available in most public and private hospitals in the country. But having said that, there's still, issues of cost, there's issues of accessibility. And to make screening cost effective, it clearly must be targeted screening.
Correct.
So we wouldn't advocate screening for everyone. At Lung Cancer Network Malaysia, the agenda we have pushed is to screen two key groups. One is individuals who are current or former smokers, so they have a significant smoking history of approximately 20 years.
Mm-hmm.
Moving away from pack years, keeping it quite simple. If you have a history of smoking on and off for 20 years or more, and even if you've stopped smoking, you have a risk of developing lung cancer. And therefore, these are individuals, if you're over the age of 40, 45, you should give consideration to be screened. The other group that we would also recommend are the high-risk non-smokers, whom I would define as individuals, as we mentioned earlier, who have a family history of the disease. Again, most relevant if it's a first-degree relative, like a sibling or a parent. Now, technology has evolved, and I have a lot of interest, and I see a lot of future in using chest X-rays as well. You'll be aware as well, the government has rolled out as part of the Lung Health Initiative. They're using AI-enabled chest X-rays, and I'm happy to share that actually Lung Cancer Network Malaysia pioneered the use of artificial intelligence-enabled chest X-rays around 2021 to 2023, 2024. We did this in a primary care setting, working with GP clinics, and the technology, because a traditional conventional chest X-ray is not good enough. For the purpose of screening, we're hoping to pick up the disease early when the tumor is quite small and you really need a CT scan. But where I see a potential role with the X-ray is AI enabled, like the technology, the software using different deep learning algorithms, it is very intelligent and it can help the radiologist. It has been shown to enhance the diagnostic accuracy, improve the sensitivity. So I think it is not to replace the low-dose CT scan by no means. That's a gold standard. But it can be, utilized as a triage, as a pre-scan investigation. Because an AI or a chest X-ray, it's not expensive at all, very minimal radiation. The software can be deployed remotely. The one we used in our feasibility study was cloud-based software. You can install it in any clinic up and down the country. So we can improve the accessibility and equity, in terms of anyone being able to access an X-ray. And then I guess those individuals who have, an abnormal or suspicious, equivocal finding on the X-ray, they should then go on to be further investigated with the gold standard low-dose CT scan.
Okay.
The final thing, Vishala, to mention with regards to screening is that this whole lung cancer space is very exciting. And I'm sure many of your audience have heard of terms like liquid biopsy or, cancer in a drop. And the medical term for that is ctDNA, circulating tumor DNA. We know that the tumor sometimes will shed some of the cells, the cancer cells, either through a process called necrosis or apoptosis, which is referred to as programmed cell death, or just through active secretion. It's a mechanism for metastases and spread. And there is technology that can detect from a simple draw of blood, and then you extract plasma to look for these circulating cancer cells, what we call as ctDNA. It is being widely used. It remains to be seen whether it is going to be good enough to be used as a screening tool. I see it as something to augment, to enhance the imaging. It may help us as doctors, as clinicians, to work out what's the next step with someone who has an abnormal chest X-ray or an abnormal LDCT scan, in terms of should we just monitor them with a follow-up scan, or perhaps do we need to arrange for a biopsy, or should they go for surgery? So it is being used for patients with confirmed lung cancer. We can monitor in real time their response to treatment, be it surgery or therapy or immunotherapy. It is being used to monitor for residual disease. The term we call is MRD, minimum residual disease. It can be used to monitor for relapse or recurrence, and then you correlate that with the CT scan or the PET scan. And it has prognostic information as well, a predictive value. So we know from quite a few landmark studies and trials in the last 1 or 2 years that, for example, patients who have confirmed lung cancer and who are ctDNA positive before surgery or before treatment, if they remain ctDNA positive even after the treatment or after the surgery, that means they're still detected at molecular level, there's detectable cancer cells in the blood. We know that correlates with a slightly worse prognosis in terms of overall survival or in terms of the cancer-free survival. But to come back to your question in terms of screening, as it stands, it'll be low-dose CT scan. I see a potential role for AI-enabled chest X-rays. And of course, the dream and hope is that the circulating tumor DNA, a simple blood test, will feed in nicely and help to, support both of these kind of investigations. But that remains to be seen, because when we talk about screening early stage, the tumor burden may be quite low.
Mm-hmm.
That creates a technical issue in terms of whether the test is able to detect that very low tumor burden.
Interesting how with technology now, we have all this different information coming together to support doctors and clinicians so that they get a better view of the person's condition, lung cancer condition. So, doctor, what are the main types of treatment available for lung cancer in Malaysia today?
Okay, so when we talk about lung cancer, and for that matter, any cancer, as I'm sure everyone appreciates, there are only 4 stages to the disease, stage 1 through to stage 4. And the treatment that we offer patients is very much dependent on 2 things. It is dependent on the biology of the tumor, and it's also dependent on the stage of disease. So, the treatment paradigm has evolved considerably in the last 5 years for the better. Tremendous advances in diagnosis and in the treatment. For early stage lung cancer, which we would define as all of stage 1, stage 2, and some patients with stage 3A, and even less so with stage 3B, highly selected patients or highly selected group, surgery remains the definitive treatment, meaning it is the treatment of choice. But we recognize surgery on its own is not enough for beyond stage 1A. So surgery has to be performed as part of what we call as multimodal treatment in combination with perhaps chemotherapy or immunotherapy or oral targeted therapies. Sometimes these treatments are delivered before surgery. We call this neoadjuvant. And sometimes it is given after surgery, and we refer to this adjuvant therapy. And sometimes it's given both before and after surgery, and we call that a perioperative or a sandwich kind of protocol. As we move to the more advanced stage of the disease, like most cases of stage 3B, definitely stage 3C at the moment at least, and most cases of stage 4, then there's very minimal to no role for surgery, certainly not with what we term as a curative intent. With early stage, the goal of treatment, Vishala, is to cure. We hope to cure the patient, rid them of the cancer, give them the best chance of long-term survival and cancer-free, or what we call as disease-free survival. But as we move to more advanced stages of the disease, the objective of treatment is to control the disease and get that patient to live as long as possible and with the best quality of life as possible. So we've kind of moved away from the term palliative, and perhaps a more accurate term is non-curative treatment. So the treatment that is offered and the prognosis is very much stage dependent and on the biology of the tumor. So the more advanced stage lung cancers, most of the stage 3 and stage 4s will be treated by the oncologists or some of the chest physicians, pulmonologists who treat lung cancer. And that's usually a combination of chemotherapy with radiotherapy, sometimes immunotherapy, and sometimes just taking a pill, oral targeted therapy. And that's where the biology of the tumor, no 2 tumors are the same. These days, we are really in the realms of precision diagnostics, precision medicine. We're able to establish what type of lung cancer it is. The most common, of course, is non-small cell lung cancer. And in Malaysia and globally, within that, adenocarcinoma is the most common subtype. But then we can do the genomic molecular profiling to see whether the cancer, for example, expresses certain mutations, what we call as actionable sensitizing mutations, like EGFR, which is the most common in Malaysia, or ALK and so forth. And also we measure a certain uh, tumor biomarker we call the PDL1, programmed cell death ligand 1. And that gives us an idea who are the patients more likely to benefit from immunotherapy. So it's very much the biology of the tumor together with the stage of the disease. And of course, then we need to see the individual patient and see if they're fit enough for that particular treatment. It's shared decision making with the patient and family. And then we also have real world issues of cost, because unfortunately, a lot of these treatments, surgery aside, a lot of these treatments are quite expensive. Yeah.
Yeah. So thank you, doctor. Thank you for sharing extensively when it comes to treatment. It's interesting to see how the treatment moves from stage 1, stage 2, and to the later stage of the disease. So, doctor, there's different treatments out there, there's different screenings out there. How can we raise better awareness of lung cancer in Malaysia, especially among younger or non-smoking communities?
Yeah. Another great question, Vishla. I mean, I think the first thing I want to share is we can't afford to be complacent.
Yeah.
Traditionally, we have always thought of lung cancer as an older man's disease,
Yeah.
as a smoker's disease. And, there's also been a stigma attached to lung cancer. Even amongst doctors, we might think, we may not articulate it. Sometimes you think, oh, well, he's a smoker, he smoked. And we have to move away from that narrative that, that we have to destigmatize the disease. And that's one of the things we've been focusing on at Lung Cancer Network Malaysia. The reality is, all of us have a pair of lungs, and anyone with lungs, unfortunately, is at risk. It's a disease that doesn't discriminate. It doesn't discriminate based on ethnicity or gender or social status, even in terms of smoking status. So I think as I said earlier, for screening to be cost effective and impactful, it has to be targeted. And we would still say that tobacco smoking is the most common, most identifiable, most preventable risk factor. And therefore, those with a significant smoking history should be screened or should consider being screened. And family history is the other important one, those who have a family history of first degree relatives, siblings, parents. So my message in this context would be, we can't afford to be complacent. If you have those symptoms, either you're in the high risk group or you have symptoms, a persistent cough, recurrent chest infections, we shouldn't dismiss that, ignore it saying, well, I don't smoke, so there's no way I can get lung cancer. Unfortunately, it doesn't work like that.
Yeah.
We must maintain, we have to be vigilant up to a point and have a low threshold to get checked out if things don't seem right. Yeah.
Okay. Thank you, doctor. Doctor, how would research help in clinical management of patients? I mean, just to talk about why is Cancer Research Malaysia here and why is research important?
Yeah, so I mean, let me put it out there and say Lung Cancer Network Malaysia, delighted to collaborate with Cancer Research Malaysia, and thank you for inviting me on this webinar today. I think research is incredibly important, and the work CRM is doing is so important for a number of reasons. Most of the advances, most of the innovation in medicine and science comes from research, right?
Yeah.
New drugs, new treatments, new procedures, new interventions. It is all built on scientific research. What starts in the laboratory, and then we talk about from bench to bedside, and then it's translational research that comes into clinical practice. And it's this research that will shape clinical practice and become the new standard of care. So, for example, 5 years ago, nobody would have talked really much about immunotherapy for lung cancer. And that has emerged now as a real potential game changer. And it's on the back of research. And yes, a lot of these are phase 2, phase 3 randomized global trials. Why I think it's so important we also conduct research locally, like what CRM is doing, is because our populations will be different and the disease biology is different in Malaysia or Asia, right, compared to, say, in the West. We have perhaps, a greater proportion of non-smokers or women or those of Chinese ethnicity or more oncogene-driven lung cancer, EGFR, compared to, say, Western populations. So we cannot just extrapolate all the data. What works in the UK or America or Australia may not work so well or may work better in our own local population. So I think research is so important to keep pushing the needle, to keep advancing the care. And what we all aspire to do in medicine is to practice evidence-based medicine. You
Correct.
know, we occasionally deviate from guidelines, but majority of time you need to practice sound evidence-based medicine, and that's what research does. It generates that. So I really appreciate all the work CRM is doing, not just with lung cancer. With in fact, I think I'm collaborating soon with you guys on a few projects, and that's so important. I think it just drives innovation and advances, which hopefully translates down the line into benefit, clinical benefit for our patients.
Thank you, Doctor. Thank you. So, Doctor, as someone who is involved in advocacy and raising awareness through LCNM, what will you like to tell Malaysians? This would be my last question to you, actually, for today.
Sure. So LCNM is, I will shamelessly use this platform as a quick shout out. LCNM is Lung Cancer Network Malaysia. Please check out our website if you're not familiar. It's www.lungcancer.net.my. It's an NGO that I established together with my oncology colleague and friend Tolaiman pre-COVID in 2019, because we felt there was a need for this. Lung cancer, the disease burden is high, preponderance of late-stage disease, poor awareness, and we just wanted to improve outcomes. And the website, we've developed a lot of resources over the years, which helps doctors, which helps patients, families, caregivers. And we wanted LCNM to be a credible site where you can access information that is relevant for Malaysia and Malaysians to navigate better the whole cancer journey. My message would be, like I said, first of all, we can't afford to be complacent and think, if I don't smoke, therefore I or my family member can't get lung cancer. Unfortunately, it doesn't work like that.
Yes.
Secondly, if you have symptoms, most of the time it's going to be nothing serious, but a persistent cough, coughing up blood, unexplained weight loss or loss of appetite, recurrent chest infections, please, go see your doctor, insist on a simple chest x-ray as a minimum. And the third final point is, I think, for individuals who are deemed to be at high risk, those are the tobacco smoking history of 20 years, current or former smokers, those are the family history of lung cancer, first degree relatives, please give consideration to be screened. Again, talk to your lung specialist. It could be an AI x-ray, it could be a low-dose CT scan, it could be a blood test, or a combination of these. My final message is one of hope, Vishala, because the whole lung cancer space, the diagnostic and treatment space, has evolved considerably in the last 5 years, and for the better. It's a very exciting space. We now see patients living much longer, but of course, it's not just about living longer. It's about living longer with a good quality of life. Yeah, and not suffering. So we have to put emphasis on that. But it's a disease that if we can pick up early, we can cure. It is, it's a curable disease. So the challenge really is, part of it is preventative strategies, mitigation, the tobacco control, the smoking, the air pollution. But a lot of it is being vigilant, pushing the agenda to screen the high risk, the at risk. So we pick up early, the outcomes are vastly superior compared to more advanced stage disease. And also it's incredibly much more cost effective, cheaper to treat early stage lung cancer for the individual patient or person, their family, and for society at large as well.
Correct. Thank you so much, Dr. Anand. Thank you so much for your time working closely with me and to come up with this webinar. I'm sure a lot of them out here who are listening to the webinar today have gained some great knowledge from you. So thank you for your time. I understand you had a very busy schedule, but thank you for making time for us.